All right, hey everybody. We are going to talk about drugs affecting the respiratory system today. Um, just like before, I'm going to try to hit the high points of certain slides and add just little bits of little notes to them. Try not to go too in depth on the individual drugs that are listed in here because these slides are pretty thorough on the specific drugs themselves. What these slides don't do is they don't tell you exactly when to use these medications. A lot asthma and COPD in particular have stepwise approaches you use medications for. We'll touch a little bit on each slide or each type of medication on where they fit, but your additional documents on Canvas are a lot better at that. They'll I think we have the gold guidelines and the asthma guidelines for when do you add an inhaled corticosteroid, and then when do you add a long-acting beta agonist, and things like that. And there's nice stepwise approaches. Plus, there seem to be new inhalers coming out all the time with varying combinations of medication. Not necessarily new classes of medication, but new combinations in one inhaler where maybe a patient can only needs one inhaler to control their symptoms. So when you're looking, try to look up. As you practice, look up what's on the market because new ones are coming up fairly often. A couple times a year, it seems like a new one hits the market. All right, so we're going to jump right in. We are going to talk about these categories of medications. The first three are going to be more for asthma, they're asthma, COPD, and exacerbations of those. Then the last ones are going to be for your over-the-counter cough and cold symptoms. So beta 2 agonists are the kind of backbone of treatment of respiratory disorders. Your short-acting beta agonist listed there, most commonly used albuterol. I'll tell you from a practice standpoint, in the 11 years that I've been in a pharmacy, 99.999% of what we've dispensed is albuterol. It's effective, it's cheap, it's fairly tolerable, except for a little bit of kind of heart palpitations, only for a couple seconds. Very well tolerated, and the other medications out there don't show any benefit over these. So most of it's albuterol, either in nebulizer form, or there's a couple different rescue inhalers, ProAir, Ventolin, and Proventil, which usually come about 200 puffs to an inhaler, and that's what you see patients take when they have an acute asthma attack or exercise-induced asthma or something like that. It's very quick bronchodilation and relief of those symptoms. You also have long-acting beta agonist, and a lot of these come individual, but they also come in combination, which is really where we see them used now. The individual components do have some black box warnings, so most of the time we give them in combination with some kind of inhaled corticosteroid, and there are several different types of inhalers that have those combinations. Here's an example of what is out there, the most commonly used ones, albuterol and then levalbuterol. Again, there's no benefit to these. The levalbuterol, which is a newer name brand only medication under Xopenex, can be given in, basically it's twice as potent, but given at half the concentration. So it really provides no benefit and has the same side effects. So it's just a cost to your patient, and likely that their insurance won't cover it. So definitely try to stick with the albuterol when you can. This is just a chart with the options, current options as of I think the end of or the middle of 2018 for your long-acting beta agonist. Again, beta agonists do have some contraindications, most commonly cardiac arrhythmias, uncontrolled. Basically, even though it's inhaled, there will be a little bit of systemic absorption, and it's going to work the exact opposite of your beta blockers, which are used for hypertension and heart rate control. This is it's a very small risk, and most patients, even if they have a cardiac arrhythmia, are still going to get a beta blocker. We're just going to want to make sure that the arrhythmia is controlled. So with drug interactions, the one thing I want to point out was if you have a patient who has to be on a beta blocker and has to be on a beta agonist for asthma or COPD, you want them to be on a cardioselective beta blocker. Some of our beta blockers, just for instance, metoprolol, esmolol, and bisoprolol, they only act at the beta receptors on the heart muscle. So there's no potential for it to block the beta agonist you're given for the asthma attack. If you do, there's a potential that the albuterol doesn't work, and then the patient has the attack worsens. So you definitely want to make sure it's a cardioselective beta blocker. And that's that term you're going to look for. Clinical use. They're the only thing we have for rescue inhalers. Albuterol, metered dose inhaler, 2 puffs every 4 to 6 hours. If a patient is having an asthma attack, you can do it every 5 to 10 minutes to see if they're having an acute attack. We also use these for prevention of or maintenance therapy for COPD and for asthma, and you'll see later kind of where they fit. So here we have our anticholinergic medications. These are I believe what are currently on the market. These anticholinergic medications are mainly for COPD. They're starting to be used a little bit more for asthma if the patient's kind of run out of other things to give. And you can kind of think of this in general. You can help remember this because and most of your anticholinergics, they dry up secretions, and COPD is based on the problem of excessive secretions in the lungs. They have that wet kind of cough and can't clear it out. That's just a way to keep in your head that these are mostly used for COPD. Obviously, the anticholinergics do have some bronchodilation, so they're very effective in those patients, but they're only used as maintenance therapy. They're not used as rescue inhalers. Even the ones given 3 or 4 times a day, they're not a rescue inhaler. One thing you want to keep in mind with anticholinergics is even the inhaled ones are going to cause similar side effects. Luckily, they're very well tolerated, but your patient could have dry mouth. They also want to pay particular attention to the instructions on how to use it. Some of these have capsules that you have to load into the inhaler, and you have to dump it straight into the trash. So for instance, Spiriva, if you puncture the capsule, inhale it, and then dump that capsule back into your hand, you're going to get the anticholinergic drug on your fingers. And then if you go to, say, take your contacts out, it's going to get in your eye, and that's going to last for 12 to 24 hours. So it's going to dilate your eyes and are called dry, blurry eyes and blurry vision. So you want to make sure they pay particular attention to the instructions on how to use it and how to dispose of the medication. Leukotriene modifiers, basically they have a lot of effect on the inflammatory process, and this is the most common one you've probably seen is Singulair or montelukast. It's more tolerable than the other options, and it's actually safe for children to use for allergies or for asthma. It's usually a 3rd or 4th line option for the treatment of those two. Again, not a treatment for an acute asthma attack, and you can't prescribe it to lactating women because it can excrete in the breast milk. Inhaled corticosteroids. Inhaled corticosteroids are the backbone of our maintenance treatment for asthma, and that makes sense because asthma attacks are due to inflammation in the lungs. So we're going to give inhaled corticosteroids to apply steroids right to that tissue and decrease that inflammation. You're going to want the patient to remember that it's to be taken as scheduled. It's not a rescue inhaler, again, and that they need to take it scheduled to prevent future asthma attacks. These are currently the corticosteroids on the market, some in combination and some by themselves. Adverse effects you want to keep in mind. The first one is thrush or oral candidiasis. What it does is because you're inhaling it, you have that corticosteroid that gets in the mouth, decreases your immune response, and the fungal infection, Candida albicans, it can happen. Now it's very easy to treat, gentian violet or just some kind of oral antifungal gets rid of it. It's not a hard to treat medication or hard to treat fungal infection, but you want to make sure the patient prevents it. Just rinse their mouth out with water after inhaling it. That way it clears all that corticosteroid out of their mouth. One thing I want to point out here is where it says may slow the bone growth in children, but a small reduction in adult height with persistent asthma. This came about from some trials that showed a decrease in growth or in height of patients. And where that might be true in the trial, the number was, I believe, 1 centimeter in the first year of use, and then growth continued at a normal rate after that. So for less than 1/3 of an inch, you have great control of your asthma. So where it may have been statistically significant in that trial, it's really not clinically significant because losing 1/3 of an inch in height pales in comparison to not controlling your asthma symptoms and having maintenance therapy. So here's a list, a list of the combination inhalers that are out there. You can see that we have some combined inhaled corticosteroids and long-acting beta agonist. So those are going to be great for COPD and for asthma. You can also have combinations of short-acting ones. They're still a couple of times a day, still maintenance therapy, but the other ones are usually used for COPD. We also have some new monoclonal antibodies that are hitting the market. So Nucala, Sincair, and Xolair. Very rarely used. It's only for severe persistent asthma with eosinophilic phenotype for the first two, or severe persistent asthma for Xolair. It's almost a last line therapy for these patients. There's also Daliresp, or a PDE4 inhibitor. It's again used for severe COPD, so a last line of defense for this. But it does reduce exacerbations and reduction of composite endpoints, which is where they're looking at respiratory function and exacerbations, hospitalizations, that kind of thing. It's important to keep in mind that none of these treatments that we're giving for COPD have any outcome of the disease. We're controlling symptoms of this. It doesn't increase or decrease their mortality risk or the worsening of lung function. If they continue to smoke, COPD is just going to get worse as they continue, even with these medications. It's purely symptom relief. Xanthine derivatives or theophylline, I believe in your book they're listed a lot earlier in this chapter. I moved them back because we really don't use these anymore. They're old. We have a lot better options out there. It requires very strict drug monitoring, lots of side effects, lots of drug interactions, and it's used so little that the manufacturers who used to make a 100 milligram, 200 milligram, and 300 milligram tablet quit making the 100 and 200. It's just not used very often. So most likely you're going to go with one of those monoclonal antibodies or that PDE4 inhibitor before you'd ever try theophylline. So here's a diagram for asthma treatment. Like I told you about these, the stepwise approach. So you can see at the top we start with step 1, no controller needed, down to step 6. So you can see as they're going, first for control medications or long-term control, starts with inhaled corticosteroids, then adding on a long-acting beta agonist. You don't want to give a long-acting beta agonist by itself in a patient with asthma, as listed in the slides before, because it actually increases the risk of mortality during an asthma attack. And basically, it may lessen the attacks, but it doesn't allow that short-acting beta agonist to work if there is an attack. So you always give it with an inhaled corticosteroid when you're at the same time as long-acting beta agonist. Then once you've added that, you're going to start adding in other alternatives, such as those leukotriene medications, Singulair, or the other ones. Most of your patients are going to be covered with an inhaled corticosteroid and a long-acting beta agonist. Right now, I think they're currently developing guidelines to put the anticholinergic medications on here, and you're probably going to see those come in step 4 or 5, later in therapy, but as an option before theophylline and those monoclonal antibodies. COPD, another chart here. It shows that your drug of choice is along with your short-acting beta agonist rescue inhaler, you're going to use an anticholinergic medication. Then you're going to add a long-acting beta agonist. Then you might add on an inhaled corticosteroid at the end. It's really just to see if there's any benefit from that. Most of COPD is not from an inflammatory response, but you may get some benefit. Then you may have to add on the PDE4 inhibitors or one of those monoclonal antibodies. Oxygen, most patients with COPD will eventually, and emphysema will eventually get to where they require oxygen. It's commonly used for patients towards the end of their life. All right, antihistamines, we're all probably very familiar with antihistamines. You have your H1 blockers, your histamine 1 receptor blockers. That's your allergy medications. Benadryl, loratadine, the whole list of over-the-counter medications. Your first generation ones like Benadryl or anything that's seen in a sleep aid causes lots of sedation. Second generation, Zyrtec, Claritin, Allegra causes very little sedation and is usually used for seasonal allergies where a patient has to take it every day. You can see a whole list of adverse effects on here. The ones you really only need to remember there's 4 of them. It's dry mouth, dry eyes, decreased urination, and constipation. And it's all based on drying up of fluids. And the saying we always have is can't see, can't pee, can't spit, can't, you can fill in the last one. But it's an easy way to remember of what your patients might complain about. And if that's the case, they need to take these medications every day. Get them some artificial tears for their eyes. have them drink more fluid for their urine and their bowel movements, or they may need to add a stool softener, and then just drink more water for their dry mouth. It's an easy fix, and usually it doesn't get to a point where it's causing a severe problem for a patient. Decongestants, there's a lot of versions of decongestants over the counter. There's not a whole lot of actual differences in the medication. Most of your tablets or liquids are one of two versions. There's either phenylephrine or there's pseudoephedrine, which is kept behind the counter, and you have to show your driver's license to get it. The other option is nasal sprays. The most commonly used one is Afrin, which has a very quick effect, but if used for more than 3 days in a row, it actually causes rebound congestion. So you want to limit your patient's use of it. After 3 days, it kind of becomes a cycle of having to use it sooner and sooner, and the congestion just comes back worse. As far as the phenylephrine and Sudafed go, which I believe, here we go, oral decongestants, those are contraindicated in patients with uncontrolled high blood pressure, and there's actually a product, a couple products under the name brand Coricidin that are made for patients with high blood pressure. They keep those out. You can potentially use these oral decongestants if a patient has controlled blood pressure and a low risk of a cardiac event, but a lot of people just play it safe and go with the Coricidin, and then maybe recommend a saline nasal spray for patients with sinus congestion. Antitussives used to self-treat coughs. There's really only one over-the-counter, and it's dextromethorphan. Everything you see with that's for coughs over-the-counter is dextromethorphan. It may be in combination with other medications, or it like Dayquil. It's got Tylenol and it's got a nasal decongestant in there along with dextromethorphan, or it may be like Delsym, which is just a 12-hour version of dextromethorphan. It's all the same thing. You just pick the one that's most beneficial to your patient. Either try to cover several symptoms with one tablet, or give them a long-acting relief by recommending the Delsym. Guaifenesin or Mucinex is an expectorant. All this does is loosens up that phlegm in the chest so that the patient can actually clear it. It doesn't actually make the phlegm go away. A lot of people forget this. You have to drink a lot of water so that it loosens up that phlegm, makes it thinner, and then the patient can cough it up. The evidence of this working is iffy, but it doesn't hurt. There's not very many drug interactions, not a lot of no real side effects. So if your patient wants to take it, by all means, go ahead. The one thing I do warn people is that if you take this, and a cough suppressant, you may be kind of, inhibiting the benefit of the Mucinex. If I don't cough, I can't clear the phlegm. So, I try to get them to maybe take the Mucinex during the day, clear everything out, and then take the cough suppressant or the Delsym at night so that they can get some sleep and get rested. These side effects for guaifenesin, most common, those hardly ever happen. It's very, very tolerable. All right, real quick, we're going to talk about fluoroquinolones, commonly used for actually several types of infections, and you'll see that in your notes. We don't have just one section on antibiotics. They're kind of spread out where they can be used. So fluoroquinolones are here in respiratory infections, but you can also use them for GI infections. You can use them for urinary tract infections, but they are commonly used for respiratory, so they're kind of matched up with at least one disease state that they're used for. Your fluoroquinolones that you're going to see most often are ciprofloxacin, levofloxacin. Every once in a while, you'll see like a gadifloxacin or other options. They pretty much all treat the same bacteria. It's just how many times a day do you use them? And certain ones are losing efficacy versus certain respiratory infections. The latest guidelines are somewhat recommending not using fluoroquinolones for infections anymore because they think we've overused them so much that there's too much resistance. If you've got a patient who has a simple infection and the culture comes back susceptible, go ahead and use it. But don't be surprised if what you're treating ends up coming back resistant. As far as adverse drug reactions, there's a black box warning for tendinitis or tendon rupture. This is important to tell your patients if they're elderly or if they're very active. Try to tell them to try to lay off the exercise until they're done with their regimen. Other than that, you want to, it can cause some QT prolongation, so you want to look for if your patient has like an atrial flutter or an uncontrolled arrhythmia, and you want to avoid it in pregnancy. Clinical use, commonly used for complicated UTIs, prostatitis, pneumonia, not Cipro because it's losing its efficacy, and some skin and bone infections. You want to tell your patients that as far as interactions go, that food can delay its absorption, and if it's given with anything that has aluminum, magnesium, or calcium, like a multivitamin or Tums, it actually can chelate the drug and it causes it to not be absorbed by the stomach. So you want to separate those by at least 4 hours. Luckily, that shouldn't be hard. Even if you have Cipro given twice a day, just ask them to take their multivitamin or their other medication at lunch, or to just hold off taking it while they're on their antibiotic. Clindamycin is commonly used for gram-positive infections, so staph, even methicillin-resistant staph. It can be good for skin infections. Is pretty good for. It's a pretty strong antibiotic, and it's great because it comes IV and PO. So you've got a patient in the hospital with MRSA. If we can get them on clindamycin, we can get them discharged faster. It's great for patients who have a penicillin allergy, who have MRSA or strep infection when necessary. Antivirals for flu, for influenza. The most common one you're going to see is Tamiflu. It's given, basically you can give it for treatment of influenza or for the prevention of influenza for a patient's family. So it's great if you have if someone comes in that has flu, you go ahead and you might want to write a prescription for their spouse or their kids for prevention of it. Then they can pick it up and decrease the risk of spreading it to everybody else. Pretty well tolerated. Can cause some ADRs. You can see it's bronchitis or shortness of breath. It's pretty rare. Commonly used for patients during flu season. You can see here treatment for flu is once a day for 10 days, and prophylaxis is twice a day for 5 days. And that's pretty standard dosing, and it's also available in an oral suspension for children if needed. Older patients can have some confusion or hallucinations. It's because of their decreased renal function, and they're just not clearing out the drug fast enough. So it is dosed based on renal function for age for the elderly. This is a brand new antiviral that just hit the market for flu. Haven't seen it used, but I want you to have a little bit of information on it as we see how much it's actually going to be used. Okay, that's it for respiratory system. We're going to real quickly go to, I think, nicotine cessation. Just a few, or smoking cessation. Few notes on that, and then we'll end this up. So nicotine cessation is we have a lot of great options for nicotine withdrawal. You always want to make sure that a patient is wants to quit. You always want to ask your patients if they're ready to quit. If not, just let them be. Tell them that if when you're ready, let me know, and we can work on this plan together. That way they don't feel like they're being judged, but they also know they have a resource to come to. You want to use the 5 A's with patients. So ask, advise them the benefits of quitting, assess how ready they are, assist them, and then arrange for follow-up afterwards. Options: nicotine replacement therapy, bupropion, and varenicline. All very well, all very good at reduction, and they can be used in combination, nicotine replacement with one of the other 2 medications. So you can see here where they fall into which one you might use. Nicotine replacement, you can use gum, a patch, a lozenge, or by over-the-counter or prescription nasal spray or inhaler. Not commonly used because usually not covered by insurance. You know, they'll cover a hospital stay for complications of COPD later in life, but you know, Lord forbid they cover an $80 inhaler. But you know, that's a different topic for a different day. Let's see, nicotine gum. The dose is based on how many cigarettes you smoke a day, and then you want to make sure they chew it and then park it in their cheek, between their teeth and their cheek, so the nicotine absorbs and gets in their system quickly. Lozenge, same thing, just let it slowly dissolve. Nicotine patch is great. You can use it 24 hours, or you can take it off at bedtime because it does have a tendency to interfere with sleep, causing some very vivid dreams. So that happens, just have them take the patch off when they go to bed. So bupropion, great for smoking cessation. You start 1 to 2 weeks before your quit date. On your quit date, you go cold turkey, and if you need to, you use nicotine replacement products. And the theory is that it decreases your cravings for nicotine as you're using it. Chantix is works on a serotonin receptor, and you start a week before your quit date. There's a scheduled dose, and there's a box that it comes in, a little kit, and you continue therapy for 12 weeks. Fairly tolerable. There can be some neuropsychiatric symptoms, changes in behavior, agitation, depressed mood, suicidal ideation, and suicidal behavior. It's a low prevalence, but it can happen. So just warn your patients that if it does, we can change the medications and it'll go away. All right, so that's a quick overview of smoking cessation. Again, there's extra notes on Canvas for comparing the products. If you have any questions, just give me a call or give me an email. Shoot me an email.